वो चल गया अभी। वो लिंक मैं लिंक तुम्हें भेज दूँगा, तुम उधर से खोल के देख लो, ठीक है?
उधर से
ये माइक ऑन कर लो।
कौन सा माइक? इधर 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 मशीन तो आ रहा है ऐसे। अच्छा बहुत चेंज करेगा
क्या?
बैटरी चेंज कर देगा?
बैटरी जी मैं उधर लगा दिया बैटरी ने यार।
तो नया लगाया ना?
हाँ तो इसे चार्जिंग लगा दो, इसे चार्ज लगा। हाँ? इसे चार्जिंग में लगाओ ना, मोबाइल बाद में लगाओ।
नहीं लगाता है छोटा है।
चलो तो ये ना हो, मुझे 6 बैटरी बढ़ाए। 6 बैटरी ये वाला मैंने लिंक भेज दिया इसका, ठीक है? लिंक तुम्हें भेजा ना पहले?
नहीं।
ये लिंक देख लो तुम।
अच्छा एक बात सुनो, अभी तुम तो जा रहा है, कभी मसला बनेगा तो ये ब्रश कि इधर क्लिक करेगा, बाद में वो
स्टार्ट आ जाएगा बस।
नहीं उधर करेगा, बाद में यूट्यूब स्टार्ट आएगा, बाद में यूट्यूब लीव आएगा। तो इतना ही ना
बस, कुछ और किसी चीज को मत देना, वो ही बस करना है। मेरा लिंक भेज दूंगा, ठीक है? तुम इसको ऐसे जब इसको लेबर ऐसे करेगा ना, तुम इसको हिला देगा ना, तो ये कभी ऑफलाइन नहीं होगा।
उस टाइम अभी मालूम पड़ गया, जिस टाइम उधर सो रहा है ना, जिस टाइम सो रहा है ना वो बंद हो गया, तो मैं ऐसा किया।
क्या कर रहा है? जो इसमें क्या रखा तुमने? भेज दे, ठीक है? मैं जा रहा हूँ। ये भाई काम मत करो।
करेगा
तो तुम्हारा भी तो करेगा।
मैं शरीर बाकी नहीं करता।
शरीर मैं काफी शरीर जा जाके माइक ऑन कर उसे, चल।
तो लेवल तो भोजन मेरे पास नहीं दिया।
मैं कितने से दूँ भाई?
ले लेगा तुम,
नहीं लेगा भाई, मैं देगा नहीं, बता देगा तो काम।
इसमें कोई फर्क नहीं पड़ता।
I didn't even win. So just some ideas about
कितनी बात है ऐसे करना पड़ेगा? कितना मिनट बाद ऐसा करना पड़ेगा?
10 मिनट के बाद, 15 मिनट के बाद, 15-20 मिनट बाद फिर दोबारा चला दूँगा। ऐसे इसको
डिस्टर्ब नहीं चाहिए।
मैं जा रहा है शाम को, तो अच्छा
Good evening, everybody. I hope that you all enjoyed your lunch. Our first speaker after lunch is Dr. Ahmed Jeffrey from King Fahd Medical City in Riyadh. He'll be speaking about the role of MRI and sports injuries of the knee. تفضل دكتور أحمد.
Good afternoon, everybody. Dr. Ahmed Jeffrey, thank you for this kind of introduction. I'll be speaking today about the role of MRI in sports injuries of the knee. As we all know, knee injuries are common because of the inherent instability of the knee joint and its involvement in complex biomechanics. And MRI was first introduced back in the 1880s, so MRI is a kind of millennial in this regard. And injuries in sports medicine can be either acute or chronic, and they involve many structures, either in isolation or combination. But commonly, the cruciates, the menisci, ligaments, are be emphasizing the cruciates and to a lesser degree cartilage and tendons in this talk. And the rest will be carried out by the remaining speakers. So, in the era of the current transformation and the imaging 3.0, we're asking ourselves, what's the value of what I'm doing? This is kind of this formula has been thrown around in the circles of the transformation program, which is, what's the value of what I'm doing? What's the cost over quality? If we don't pay attention to these, you'll get these kind of publications elsewhere from other specialties. Can we really trust MRI? So how can we increase our market value to our referring physicians? Basically, we can address it from four basic domains: the accessibility to the scan, the accuracy of our reports in comparison to the known gold standards. We will try to eliminate and artifacts and improve the image quality. I will try to, as much as possible with the improvement of technology, to depict anatomical structure that were not previously depicted. So back in the probably 15 years ago, MRI, as all of you recall, the knee required like probably 45 minutes to be completed. Nowadays, we're getting ahead of ourselves and we're producing more efficient imaging. Like for example, in this paper, they've illustrated the use of ecoplanar 2D fast spin echo imaging to obtain a multiplanar MRI of the knee in just 5 minutes. So imagine how that would cut down on your waiting list and increase the trust of your referring physicians. So anyone who's working in any administrative circle will immediately recognize this as being the famous Venn diagram. So we'll put a spin on it. The gold standard of diagnosing intra-articular derangement is, by definition, is arthroscopy. MRI can aid significantly with areas that it can approach the same sensitivity as arthroscopy, which is the gold standard, namely in cases, for example, full thickness ACL tear, displaced meniscal tears, obvious cartilage fragments. But there are areas that we miss, namely if you have a single bundle partial thickness ACL tear, that will be difficult for us to ascertain, especially if we don't have an optimized protocol. And not only that, also arthroscopy has its own limitation. First of all, it's an invasive procedure. The cost of the procedure itself. The other thing is that the famous thing that they miss is the intra-substance ACL sprain, which is not clinically that relevant in changing the patient management. We'll start off with the anterior cruciate ligament. As you all know, it is composed basically of two biomechanically distinct bundles, the anteromedial and the posterolateral bundle. It's the primary restraint against the knee flexion. So when originated, then this is a traumatic cartilage defect, and if it's other than that, then probably it's degenerative. Cartilage flap, typically seen in very easily if you have an inherent joint effusion. But other than that, MR arthrography or CT arthrography even can depict it to a greater extent. So in conclusion, MRI is an important modality in investigation of acute sports injuries. Knowledge and optimization of the technique and the limitation of the MRI versus arthroscopy should be in the mind of anyone who's reading knee MRIs. And thank you for your attention.
Thank you, Dr. Ahmed. It gives me a great pleasure to introduce our next speaker, Dr. Adnan. He is from University of Oxford. You heard him morning talking about muscle imaging, and he will be giving us another talk of the anterior.
Thanks, Tariq, for the kind introduction. Again, thank you for inviting me back to Saudi Arabia. It's been a pleasure to be here. And after 2 bowls of Omali, I am very sleepy, so I just want to finish this. I'm just kidding, yeah. It's been a pleasure here, and the food has been excellent. I hope Ramadan comes soon so that we can get back to my shape there. Okay, let's start talk about assessment of anterior knee pain. Again, those are my disclosures. We're going to talk about the normal anatomy of the anterior knee, and also we're going to look at identify the causes of anterior knee pain